Dr. Shushant Mane, he is an associate professor and nodal officer pediatrics at the State Center of Excellence for TB, Department of Pediatrics, Grant Government Medical College, Sir JJ Group of Hospitals, Mumbai. His areas of interest: pediatric pulmonology, especially TB, asthma, chronic lung disease. He has a long list of achievements and numerous publications. So I would now invite the panelists for the, I would now invite Dr. Vijay Shekharan, who is the lead discussant for the talk. The other panelists are Dr. Sarika Gupta. No, this will be later. Dr. Sarika Gupta, Dr. Shantanu Bhakta, Dr. Shudeep Shaha, and Dr. Sanjeev Singh Rawat. I'd request the moderator to kindly introduce the panelists in short.
So good afternoon everybody, and welcome back to the post-lunch sessions on the concluding day of Respicon. I thank the organizing team for having all of us here. So what we are going to discuss in the next, say, 30 to 45 minutes is what are the topic says what are the challenges or what are the dilemmas in the management of childhood tuberculosis. Now, as we all of us sitting here know that TB is one of the most common diseases or disorders which we think of, especially when we think of India. And TB comes as a differential diagnosis of almost all conditions. But many of us who have attended sessions yesterday and even today morning, we have had such beautiful case presentations where TB was diagnosed as empirically, started on treatment, and then it came out that that was not TB. Okay, so this is an area where we want to learn how do we diagnose TB in an appropriate way and how we start treatment to the patients in an appropriate way so that it is not only underdiagnosed, but it is also not overdiagnosed and the other disorders are not missed because of the empirical diagnosis of TB. So we will be having cases. These are all cases which are real cases which have presented to our institute, and then we'll see how it is managed one by one, and my expert panelists are going to answer the cases. So the first is, so this was a 6-year-old boy, Jignesh, who presented with fever, cough since 1 month, weight loss. Weight was 12 kgs. The child had pallor. Air entry was decreased on the right side. CBC was okay except for anemia. That was the X-ray of the child. That is, you can see opacity on the right side of the patient. So the first question to Dr. Bhakta would be, this is a common scenario which we have in our clinical practice. What do we do next when we have such a patient?
So we have to characterize the symptoms, detail. So the fever we have to document it either by the parents or you have to objectively document at least once. Persistent, unremitting fever with apparently no cause. You have to detail the cough, whether it is persistent, unremittent. And weight loss, you have to take care whether there is a definite weight loss more than 5% in last 3 months or there is no weight gain provided the adequate nutrition in the past 3 months with again no other apparent cause. So we have to take the detailed history like this, and we have to take any contact history of any infectious TB patient, and we have to take the past any history of past illness, any treatment received. So these are the things we have to characterize.
Yeah. So this is pertaining to pulmonary. Can you throw a light certain amount on extrapulmonary?
Extrapulmonary, so like
apart from these symptoms,
peripheral paleness swelling, as in lymph node TB, meninges of insidious onset in CNS TB, spine gibbous in skeletal TB, and any non-specific symptoms in contact with the TB infectious patient.
So the last line is important. Whenever a patient presents with any symptoms which are true symptoms persisting for more than 2 weeks, we keep TB as one of the differentials. So this was all done for this patient, as what sir said, characterization of symptoms. But before that, when we have characterized these symptoms, now there is a terminology is what we label as a presumptive TB. So, Dr. Sarika, when do we label a patient in our OPDs or clinics that this is a presumptive case of TB?
So presumptive TB is labeled as a case, so there are certain symptoms and for certain time duration and with certain prefix. So a fever which is unexplained by any other reason for more than 2 weeks, cough which is unremittent for more than 2 weeks, or history of weight loss. This should be a documented weight loss. That is a weight loss of 5% as reflected in this slide, or no weight gain is past 3 months, or despite that NRC being given, the child is not gaining the weight, or any non-specific symptom in context of a presence of a contact in the family in last 2 years. So
Absolutely.
these are the cases which we label as a presumptive TB
Whenever
cases.
we have these kind of symptoms, we would label this patient on our paper as a presumptive case of TB. And then how should we proceed now when we have this presumptive diagnosis? As Dr. Bhakta rightly said, that we would be needing extra information like history of contact with an index TB case, which was not there in this patient. Treatment was taken in a period of 1 month. The child was given multiple courses of antibiotics. So again, now the question comes to us, once we have done this, once we have this background history, what should be the next test, or what should we plan, or what investigations do we plan in this patient, Dr. Sir?
Actually, we have an X-ray like this, so definitely we need to know what's inside. So the best way possible is that we should go for an ultrasound to find out whether there is any collection or not. And if it can be an USG guided, if there is any collection, we can tap that effusion or anything. So if it's a pus, then it's a different issue. If it's not pus, then definitely we should send it for cell type, cell count, and
so
if
this
possible
patient had
gram stain also.
Exudative pleural effusion with on ultrasound. Do we start anti-TB at this stage in this patient?
Definitely, as we have suspected a presumptive TB because there is a fever of more than 1 month. We did not get the weight loss, but definitely cough is there. So better to start if with this picture of pleural tap of 450 cells and protein being 95. 4.8 gram. So definitely I will start.
Before starting anti-TB, so it is fitting.
Definitely I will send for CBNAT,
and
I will go for a Mantu test. Definitely that will be my subjective issue.
Right.
So pleural fluid for CBNAT, or if it's possible, either a gastric lavage also to be sent.
Absolutely. So CBNAT has to be tried in each and every patient. That is what is the message. Now here in this patient, CBNAT on the pleural fluid was done, which came out to be negative. CBNAT was also done on the induced sputum. Now it is always said whenever we are also dealing with a patient of pulmonary TB, also look at the extrapulmonary TB, also look at the chest X-ray because there might be a focus. Around 25 to 30% of EPTBs have a pulmonary focus, and you can send a pulmonary sample. But in this case, everything was negative. Yes, sir.
I think CBNAT, probably it's a very good test, microbiological test. But when come to the pleural fluid, that detection rate
the sensitivity is
drastically. I think in this situation, we can also do a gastric lavage.
Yes.
I said already it's a gastric lavage, or if it's an elder child, then we can go for induced sputum also.
Yes, absolutely. So that is what is
but
the
definitely
message.
we should send a CBNAT. That's
correct.
Maybe.
That is no question. Why you waste money for a pleural?
Because the sensitivity is more for compared to a TB meningitis. The pleural fluid sensitivity is more for CBNAT compared to, I think so, most likely.
So
Induced sputum.
gastric aspirate. That is what sir said. So if the child is not able to expectorate, we have to do a gastric aspirate or a gastric lavage and send the sample for molecular test and culture. So as we saw in this case, it was a case of pleural TB, clinically fitting into it, but the tests have come negative. Okay, so that brings us to the question, Rawat sir, what are the challenges we face when we talk about pediatric TB diagnosis?
Good afternoon all. Thank you very much first of all for inviting us for this very important panel. Now there are a lot of challenges in diagnosis of pediatric TB. First of all, the disease is possibility. All the specimens may be from GA or IS or BAL specimen. It contains very few bacilli. So all the tests they have got low sensitivity. Then second, it is difficult to get a sample. Like for example, getting an induced sputum from a child who is 2 years or 3 years. Sometimes it becomes very difficult. Then GA, sometimes parents they don't agree for that. Admitting, putting the tube in the, it's very difficult. Getting a BAL or bronchoscopy. So it is really difficult to get a appropriate sample. Then in the past there were no good point of care, but now currently we have got CBNAT, so again it is not there. Then there could be a lot of personal intra-observer difference. Like for example, X-ray chest, you see that somebody says that it is typical of mediastinal node, somebody says it is not. So sometimes there is a lot of overlap between the advice, and sometimes your presumptive diagnosis is not clear. So there are a lot of challenges in diagnosis of TB in a child.
So that is very well explained. And now, since we are moving towards our goal of elimination of TB, the whole focus not only of WHO but the NTP India since 2017 has shifted not only on efficient diagnosis of MTB, but because India reports one of the largest number of cases of drug-resistant tuberculosis, in addition to picking up MTB, we also want to pick up upfront resistance to the key drug, which is rifampicin. And therefore, we have come across, or we have put forward a concept of universal DST. Sir, can you explain what is a universal DST, what we are doing now?
Again, this is a very important aspect of NTP, where universal access to detect resistance to rifampicin should be there for all. So whenever you do any diagnosis of TB, you must have an access to rifampicin. And in case you detect rifampicin resistance, you must have access to at least fluoroquine sensitivity. So these two things are very important. Universal access to rifampicin resistance, and in case if you detect rifampicin resistance, you have to have access to at least fluoroquine. So this is a part of NTP program available to all across India.
This is very important because many of the times now we are aware that rifampicin is tested, but once rifampicin is tested, people stop. If the message here is, if rifampicin is resistant, we have to go ahead and document a fluoroquinolone resistance, because India overall reports a FQ resistance of around 40%. So it's a very high number. So we don't want to miss this pre-XDR cases. Having said and done all, said all these things,
Manik,
the most...
I think among the tuberculosis means the drug-sensitive tuberculosis is the one maximum still in India.
Yes.
It tunes to around, I am telling, to overall
90% is still drug-sensitive.
94%.
Yes.
Oddly, we are left out with the fight as 6 to 7% is going to the resistance.
Yeah.
I think still, don't worry, you have to carry on your test.
Yeah.
I think microbiological test is very, very important. And we also do this. Actually, these two tests is becoming very important. That is CBNet and that liquid culture.
Yeah. So then, whatever we say, if we don't send a proper sample, our tests are not going to come positive. I work in a medical college, and this is what we experience, that we ask the residents to send without supervision, and even in a miliary, the test comes out to be negative. And then when we do it in a proper technique, it comes out to be positive. So sir, Bhakta sir, what are the samples to be sent or can be sent when we talk about pulmonary TB?
Okay, the first one is coughed out sputum or self-expectorated sputum. If you don't get it in case of children, it might be difficult sometimes. You can go for alternate sample like induced sputum or gastric aspirate. And even then, you can go a little farther for advanced sampling like bronchoscopy and BAL and esophageal bronchoscopy, ultrasound guided, transbronchial needle aspiration of mediastinal nodes, and tissue biopsy also you can do.
Yeah. So the thing is, send the appropriate sample. A child by and large 6 years and above would be able to give an expectorated sputum done in a proper way. Below that, yes, we have to do gastric aspirates. Sometimes even a 10-year-old child is not able to bring out sputum, then also we can do a gastric aspirate in such a child. BAL, although looks very promising, but there are ample papers to show that a properly collected gastric aspirate and induced sputum is not superior to BAL. So let's not just, jump up doing bronchoscopies for every patient to get a sample. So coming to the next question, Dr. Sarika.
And then again, I think we should try more and more for specimen from lungs, pulmonary specimen, because you can apply direct LPA. So in case if you get a sputum directly,
yes,
or you get an induced sputum, you have a benefit that you can apply direct LPA and the things may become
so that is what we are going to discuss. Dr. Sarika, can you tell us what are the tests which are available to us in India under the program?
So the test available for the diagnosis of TB under NTP program. So first one we all know is the CBNet, Gene Expert. Now has the updated version, that is the Gene Expert Ultra. Apart from that, indigenous method, point of care test in rural area, that is TrueNut, and another is Expert XDR. So these are the tests available for the microbiological diagnosis under the NTP program.
So out of these tests, which is right now approved under the program?
Yeah. So the approved one is the CBNet Expert Ultra, in which just 16 colony forming units are required, TrueNut, and the Expert XDR.
So these are tests which are approved by WHO, but right now under the program, the approval is only for CBNAT and TrueNAT. Ultra, though it is a useful test, it is not incorporated under the program because there are reasons why we are not included the test. So can you throw light upon LPA?
Yes. So another test
How does it help?
So another test is LPA. As with CBNAT, we can know only about the rifampicin resistance. So LPA, the first line and second line LPA. So it tells us about the resistance, first line about the isoniazid, and the second line about all the injectable and the other drug which are used for the management of drug-resistant drug. So LPA is also available under the program.
And like Sir said, if we have a pulmonary sample which is sputum smear positive, we can do LPA immediately and we get the result in 3 days.
So if it is positive, then the LPA can be done directly.
What is the gold standard?
Otherwise, culture and then followed by LPA.
So the message here is culture is the gold standard. So anytime when we are sending any sample for microbiological test, we have to always send 2 samples. So when the lab accepts the sample, the first sample is run for a molecular test, that is CBNAT. If it is positive, or for pediatrics, even if the sample is negative, the second sample upfront goes for a culture. And if the culture comes out to be positive, then we have, advantage that we can get the sensitivity depending upon the culture. Another advantage of culture is it is a most sensitive test. So your moleculars can come negative, but culture can still come positive at the end of 3 or 6 weeks. And we can get resistance or pick up resistance to additional drugs if the culture is positive. Because,
just to add information, that is, when you get a specimen, you have to, as rightly said, one is the gene expert, that is CBNAT. The other one is culture. What we mean is culture is a liquid culture. That is a midget.
Yes.
And there are culture is 2 types. One is the solid, one is the liquid. Okay. Again, the solid is the conventional one. It is a Lawrence Johnson medium. It takes around 8 weeks, then another 4 weeks and all. What we mean is the culture means it is a phenotypic culture. That means we have to send the culture for midget. So that is very, very important.
NTP we have got only liquid culture. We don't have solid culture now. The NTP approved is only liquid culture.
No. See, what I am telling is, approved is, see, I am affordable. See, if you want your child, everything cannot necessarily go through NTP. See, for example, one patient is corporate, they are coming to him, I am taking the specimen, mean we have to send both. One is gene expert, one is the liquid culture.
Yes. So, Dr. Saha, can you quickly summarize, when we have a sample, what is the order of tests that we go ahead with?
Definitely, we will be expecting our report to be very fast, and that's the CBNAT is the very fast. Definitely, within 24 hours, we expect a report to come, and definitely, everyone should be having, whether we are suspecting a presumptive TB, but definitely we need to diagnose MDR TB. It's much more important because that will be a problem to the society. So we need that CBNAT report further. So definitely if we miss the first sample, as you have said, the second sample, or if you are still suspecting a tuberculosis, definitely we can send another sample, and the proper way of collecting the gastric lavage is very important, that there should be NPM. And the patient has not to be admitted, that's also important. Absolutely. So definitely that's a very important thing that our juniors should know how to send a sample for gastric lavage.
So the message is we have to send sample for molecular and culture, and that is how
next
the lab follows.
We will definitely go for LPA. That's definitely that's the second thing that will be coming the next.
Still, after doing all this exercise, we all know because childhood TB is possibacillary, we would have certain cases that it will be still negative on microbiological tests. Then do we treat such patients or do we not treat such patients? So Dr. Rawat, can you tell us when can we start the patient, label the patient as probable pulmonary TB and start treatment?
You see, presumptive TB, we have got, as Dr. has told, that there are 3 symptoms in which you enter the algorithm. So once you enter the algorithm, then the most important thing is that you have to detect MTB. So if you are able to detect MTB by any method, you may do nucleic acid amplification test, or you do LPA. If you are able to detect MTB, probably you are very valid to start the NTB treatment. In case if doing everything, you are not able to detect MTB, then and you are very sure that this child is because having TB, then probably you can, very small percentage you can start TB and you can label them as probable TB. So again, I like to repeat is that you go through the entire algorithm and you have done all the efforts, you have done all the samples right from his conduced sputum and then GA, BAL, and extrapulmonary, you have tried to look for any focus, lymph node, exhausted all possibilities. And at the end, you are still sure that he can have TB, then probably, and there are no risks for DR, diagnosing TB. then only you are justified to start treatment for TB. Very small group where you label it as probable or clinically diagnosed TB.
So that is a very important message to be taken. The middle flow chart the sir was explaining about. Always make all attempts to get a microbiological diagnosis. Send multiple samples, look for different sites. If still not possible to isolate the organism, we have ruled out other differentials for the particular signs and symptoms, then we label as probable TB and start treatment. Quickly coming to the rapid fires, because we were discussing about pleural effusions in that particular case, Dr. Sarika, what is the role of TST, skin test or IGRA in the diagnosis of TB?
So basically these tests are used for diagnosis of infection only. So
Yes.
like a person who is TB, so in contact who are more than 5 years of age, to start TPT we have to do that. Then in contact of then in immunocompromised children to rule out tuberculosis
basically
infection.
for diagnosis of TB infection, not for diagnosis of active TB. So in the active TB protocols or algorithms, the TST and IGRA are out. So we should not rely on doing this test. They're not going to help us at diagnosis. What about the role of ADA? Because in fluids, ADA is done most frequently.
So ADA has also no role in the diagnosis of pediatric tuberculosis.
So this is specific for pediatric TB. Adults or adult chest medicine or pulmonology people rely on ADA because there the confusion when we have a fluid in the pleura is between differentiating between a malignant versus a tuberculous effusion because they have a lot amount of malignancies of the lung. In our case, we are more confused whether the pleural effusion is pyogenic or it is tuberculosis, where ADA is not going to help us because ADA levels are known to be elevated in both the conditions. Okay, so that is why ADA is not going to help us. Even if it is high, we don't know whether it is because of TB. So we rely upon other factors. And is culture mandatory? I think we have answered the question. Yes, we have to send 2 samples for each and every cases. Now coming to when we have a diagnosis of drug-sensitive TB, or in this case when we have labeled as probable TB, Dr. Saha, what are the regimens right now available for treatment of drug-sensitive TB?
Now that complication has gone away. As we know, we are all into a single one. So that's the very easy way the NTP has made us for. So whatever TB you have diagnosed, you can put it into the normal regimen. Now it's a daily regime.
Yes.
We have given 4 drugs for intensive phase, and then the consolidation phase, we have 3 drugs. And that's definitely, we have to add all 4 drugs. If we have other problems after this treatment started, then we can plan accordingly. But definitely 2 HRZD plus 4 HR, whatever the cause may be, we have to. If it's not a multi-drug, then we will not do. Otherwise, all TB to be treated in the same manner.
So the message is very clear. Any drug-sensitive TB, the regimen is same. 6 months of regimen. Only when we are talking about a neuro TB or a pot spine, we extend the therapy to 12 months. That is, the continuation phase is extended to 10 more months. And the categories which we all knew, 1, 2, 3, 4 are now gone. There are only 2 categories of treatment, DS, drug sensitive, and DR, that is drug resistant treatment. And the doses have changed.
Definitely here, one interesting fact I wanted to point out that if we don't require to remember everything of if we are not available. So if anyone knows the first category, that is 4 to 7. So if we plus just add 4, 8, 12, 16
Absolutely.
for the children. So just add 1, 2, 3, 4. So that's the best way to remember. So, and if you think for the rifampicin INH dose, they are just double. If we see it carefully, the pyrazinamide and ethambutol is double of rifampicin and INH.
Yes.
So that's fixed, except for the 25 and 30 weight, that little adult has been added. So again, that's again reverse coming from if we take the 16 and then come back. So, somebody doesn't have to remember the same thing. If it's not available ready,
weight bands, our life is much more easier. Just see the weight band and put the child in that weight band. The compliance is much better. And all these tablets, what you see, pediatric tablets, are dispersible tablets. So there is no issue how the child will take the tablet, just put it in water or juice and the child will drink it. So, the compliance and the adherence to the medication improves. Dr. Bhakta, what would be the recommendations for pyridoxine?
I think we should add
routine pyridoxine is necessary for all cases of antitubercular ATT and TPT.
Yeah, so till the child is on anti-TB drugs, whether we are talking about drug sensitive or drug resistant, the child has to be given pyridoxine for the entire course of treatment. A single dose in the morning can be given. So if you want to summarize for drug resistance, what we have come across from the old versions is now, as I said, we have only single treatment. There is addition of ethambutol in the continuation phase, that is HRE. The second line or category 2 treatment has been removed completely. There is only one treatment. Daily treatment, if the patient is not responding at the end of intensive phase, that is at the end of 2 months, don't keep on extending the therapy for 1 more month, 2 more months. Start investigating. Probably this is a DR patient, or there could be any other issue in a non-responding patient. And if we diagnose a RIF resistance, the protocol changes directly to a drug-resistant TB management. So this is the second case, 4.5-year-old female, Nandini, repeated vomiting since 8 days, 2 episodes of generalized tonic seizures a day before admission. Mother was treated for pulmonary TB 1.5 years back. She had bradycardia, left-sided focal deficits. CSF showed, again, exudative picture, 170 cells, lymphocytic predominance. Here, CSF, CBNAT, everything was done, it was negative. That is the CT brain which is showing hydrocephalus and basal exudates. So this is a case of neuro-TB diagnosed on clinical and radiological basis, but we still do not have a molecular test or a confirmatory test. Dr. Sarika, do we want to start treatment or we wait till we get the culture reports in this patient?
So NTP has provided a guideline flow chart that in condition that the microbiological test is negative, even then we can start treatment for TBM. So there are 3 boxes. So criteria 1, so any 3 of these clinical radiological criteria, so symptoms more than 5 days, lymphocyte, the CBC count is less than 15,000, you have increased protein, decreased sugar, and with lymphocyte predominance in the CSF, and the imaging, CNS imaging is showing either exudates or infarcts or the hydrocephalus. So any 3 of these, then in criteria 2, so either the child is HIV or SAM or history of contact, and the criteria 3, that is the evidence of TB anywhere. So any 2 of these criteria are met, then we can start treatment for the TBM on these background, and we should try also for the microbiological confirmation. If microbiological confirmation is done, then it is microbiologically diagnosed, start treatment straightforward. Otherwise, we can start, and we should also monitor the child, so find out that is there any deterioration or it is a case, any other case. As
so the basic message why this case was put here was, now, as we know, in pleural TB, pleural effusion, we have time in hand. We can take a little bit of more time to, keep on investigating, send other tests. But TBM is one of the most dangerous conditions, and untreated in time, it has a high mortality. And that is why this algorithm has been put, that we look at these 3 boxes, any of the 2 boxes are positive, we start the treatment, but the investigations don't end if we think that there could be some other possibility. Like now, as the science advances, there are so many neurological conditions, autoimmune especially, autoimmune encephalitis, autoimmune NMDAs, the MOGs and all come with similar picture to start with. So the message here is, if it is fitting, do start, but investigate. Once the investigation is complete, put it into one of the diagnoses. Like for example, if you get an autoimmune positive, don't just keep on continuing AKT because, abhi chalu kiya to khatam karna. It's not something like that. So this case was put for that. Yes, this child turned out to be positive on culture, and this girl was a H monoresistant TB. I have not gone into the details, but the thing was. Now this is a 9-year-old child, right knee joint pain and swelling since 2 months with intermittent fever, restricted movements of the joint since the last 15 days, 26 kg, pallor, arthritis of right knee joint. CBC had HB low and platelet on the lower side, ESR was 90. USG knee had effusion, MRI showed effusion with necrosis, some of the popliteal nodes were necrotic. Synovial fluid again was exudative. CBNAT was done on the fluid, it came out to be negative. This was started on anti-TB treatment somewhere out into the practice. There was no relief after 3 months of starting first-line anti-TB treatment. That is when the child was referred to us with the thought that this is probably a DRTB. As the child was stable, there were no other risk factors to suspect DRTB. We looked into the case again. Clinically, the history was fitting. Again, the ESR was high, CRP was high. CBC was a similar picture. Because it came to an institute, we went one step ahead and did a synovial biopsy, arthroscopic biopsy, where there was no feature suggestive of tuberculosis on histopathology. The biopsy specimens were negative on molecular and culture. A rheumatologist opinion was taken, and this was diagnosed as a case of uniarticular or pauciarticular JIA. The anti-TB treatment was stopped, and the child responded to steroids and anti-inflammatory drugs. So the clues in this case which suggested that this could not be TB are persistent high-grade fever, pancytopenia on multiple occasions, very high ESR. It is always said when we do our MBBS things that if you have a 3-digit ESR, start thinking beyond infections and think about inflammatory disorders. Nature of lymph nodes was not tipping, and there were no risk factors to suspect DRTB. I have put this case purposefully here because nowadays, not only for DR, but especially in conditions like abdominal TB, we see the patient is started empirically just with seeing lymph nodes in the abdomen, USG abdomen. and then the patient comes to us after 1 year, now think of DRTB probably, and the USG is being done 10 times in a period of 1 year. So then what are the issues in a non-response? Yes.
See, among the skeletal TB, the most important TB is a spinal TB. Because, and in my practice, see, though I worked in the TB clinic for long years, I am yet to see a knee joint TB in my So common things are common. And again, among the extra pulmonary TBs, you have to think, next to pulmonary, the most important being is the lymph node TB.
Lymph node TB. So I think that is a very valid point. For osteoarticular, the commonest is for spine. And when we have knee, we should start thinking that could be something else. Dr. Saha, what are the things if a child on a first-line therapy is not responding? What do we think of?
Definitely, we should confirm because now it's not a direct observation treatment which is not being done. So we give the medicines to them. So definitely it has to be checked. They have taken the medicine or they have vomited the medicines. So that's very important. The response, whether it was taken in the proper time or not. So these are the very important things that we need to know whether if the patient is not. And definitely we should think of whether we have missed any drug-resistant tuberculosis or not in their household which we missed. So if these things are there, definitely there can be a non-response. That's very important. And definitely a paradoxical reaction can happen, as we know, after 2 to 6 weeks. So if there is increase in the symptoms, that also has to be ruled out when we are suspecting that.
So what do we want to say here is, if a child is not responding, we have put DRTB as the last, especially if the child does not have background risk factors to suspect DRTB. We have to go through this systematic exercise. Most of the times the child vomit on anti-TB treatment and the dose is not going. Adolescence is the issue. The parents think that the child, girl or the boy is taking the medications and the medications are being thrown out of the window. We have had so many such cases. So we go step by step, and if everything is fitting, yes, we do think of drug resistance. Okay? So drug resistance is definitely a cause, but it cannot be the first cause if the patient is not responding to therapy. So
I think in TB therapy, all drugs to be taken in the early morning, empty stomach.
Very important point.
So as to attain a peak concentration. So whichever bacilli that bacilli will be killed at that time. That is the reason why we are using, and so I think it's a very big subject about the lag period and all. Ideal thing is take TB, don't split the tablets, and unless sometimes then because of some reasons we may be splitting the doses. But most of the times it has to be taken early morning in an empty stomach.
At the same time.
One more thing, sir. Actually, when we are giving them the packs, maybe they have to take 4. They have to take that 4 only. That's very important.
That is what sir said.
So that's the direct observation is not there. Very important. That's
4P has to be taken all simultaneously, not morning, afternoon and evening, something like that. So Dr. Rawat, when do we then label as a child of presumptive DRTB? What are the criteria what we think of DRTB?
Yes, I think it's very important because as Dr. Saha has told, that please keep drug-resistant TB in the last, because first we try to think of drug-resistant TB and then we refer the child for the treatment of DRTB. But I think it should be kept in last, but in case we have ruled out all the things what Dr. Saha has told, then there are specific situations in which you will think of DRTB. First we have started first line treatment, 1 month to 2 months down the line, child still not responding, and there is no comorbidity. Your antenna should be up that probably you can deal as drug-resistant TB. Then a child who has defaulted, you have to give treatment for 1 month, he has run away, disappeared, again came back, still sputum positive, think of DRTB. Then relapses, a child who has been treated with your drug treatment properly, took 6 months treatment, came after 3-4 months, again he is positive and again positive microbiologically. Again suspect that he could have DRTB. Or he has been in contact with an gamma TB case, or people living with HIV, or there is some death because of TB in the family. Somebody has died because of TB in the family, or he has taken in the past, sometimes second line treatment he has taken in the past. So all these conditions, if they are there, and there are no comorbidity, always think that child could have DRTB, and again workup, do proper workup, don't start empirically, it has always to be proved microbiologically, and then only started.
So the message from what sir has said in the last 1 minute is, the first is careful history. When we want to label a child that this could be a presumptive case of DRTB, we have to take care of all these factors, do a clinical examination, which we forget. Pulmonary TB, which we are not getting a sputum sample, we do an examination, we could find a lymph node, which is easily accessible. We can do an FNAC, we can do a biopsy and send for CBNAT culture. HIV testing, not only when we are suspecting DR, but for any TB, there is a mandatory protocol that we have to do an HIV testing. And as far as DR is concerned, microbiological confirmation is mandatory before we start the patient on a DRTB treatment. If we are diagnosing DRTB more clinically, that means something is going wrong with us and not with the patient or the diagnosis. Okay, so DRTB clinical diagnosis has to be taken with a pinch of salt, and always when we talk about managing or treating DRTB, the experts have to be involved, refer to a nodal or a district center where we have the requisite expertise to manage such patients. By manage, I not only mean the diagnosis but also treatment, because treatment is a little longer treatment. So Sarika, can you just highlight what are the principles of management when we talk about DR?
So basically for the MDR treatment, so first of all, it is like it should be done in consultation with the expert who is expert in treating pediatric drug resistance TB. Then we have to follow the guideline, and it should not be like that we add just one drug, no. So from group A and B, the 4 to 5 effective drugs should be added for the treatment, and as earlier said, not a single drug to be added. And then monitoring of the, after you had started treatment, monitoring is must, first definitely by the clinical radiological criteria and also by the culture response. So, and now,
yeah. So the very important point here is what we see is, if the patient is not responding on first line, levofloxacin is added, time is wasted 1 more month, or maybe a linezolid is added and then the patient is sent to us. Never do that, never add a single drug, always treat it
I think this contest is not going to apply anymore, because now I think Varinder may be highlighting, when you are suspected of drug resistance, you have to go for statement first line and second line.
Yes,
okay,
absolutely.
Then accordingly you have to choose the drugs and all. Okay, yeah. Those sometimes before all these things that is not going to apply, but you as you rightly said, treating the DRTB is not from everybody point of view. Only the expert should do.
Yeah.
And
so coming,
so many things are happening now. I think most important thing is looking out for a family contact.
Yeah.
If it is
so
going to be
that is what the last case is.
Yes.
So the last case is 6-year-old girl, fever, cough and anorexia for 3 weeks. She was a CB-net positive pulmonary TB. Rifampicin sentinel started on DSTB treatment. Now there are 3 parents in the family and 2 siblings. Dr. Saha, what would we be doing for these patients, because they are contacts now?
Definitely, we should investigate and start treatment for the family contacts, because the child is 3 years, and so for everyone who is definitely HIV positive, definitely we need to start treatment for them also. And if they are
yeah, these are just last 2 slides. Yeah.
So if we have to go for the investigations and if we should start the treatment for all of the parents and the children who are there, who are coming in close contact. And if it's an HIV positive, then much more importance has to be given for them.
So to cut it short, all the contacts of a pulmonary TB index case, the household contacts who is sputum positive as per the guidelines now, have to be screened for active TB, number 1. If active TB is ruled out, clinical screening, or we may do an X-ray if there are symptoms, then all of them are eligible to start a TB preventive therapy. Up to 5 years of age, we just rule out active TB and start TB preventive therapy. If the child is above 5 years of age, or even in adult contacts, if facilities are available, we try to diagnose TB infection either by doing a TST or an IGRA and start TPT or TB preventive therapy. However, if facilities are not available, we should not withhold, we should counsel them to take TB preventive therapy. Now, as far as the preventive therapy is concerned, for DSTB contacts, we have 6 months of daily isoniazid, or we have a 3 months therapy of isoniazid and rifampicin. The therapy below has a better compliance because it is once a week dose and it is to be taken for 12 weeks. We have TPT for contacts of DRTB now. A pure MDR-TB case who is not fluoroquinolone resistant can be given 6 months of daily levoflox, and a H-mono can be given 4 months of daily rifampicin. What does the program offer to us? Yes. We earnest request, as far as possible, try to get associated with the program, because the patient benefits. Even if you are in a private setup, you can contact the DTO and everything will be made available to your doorstep by the program. Diagnostics is free, treatment is free. If the patient is not affording, the patient even gets travel reimbursement if he is coming from far off places. Nutritional rehabilitation is taken care by the program. 500 rupees per month is transferred to the account of the patient once the patient is registered in Nikshay. We have a 24-hour helpline which is given here for the patients. Any grievance, the patient can reach out to the program. And the Nikshay 2.0, which was launched in 2022, there is something known as Nikshay Mitra, where any person in India can become a TB supporter by attaching to the program and help the patient in any possible way. So the take-home messages is symptom characterization, that is diagnosis of presumptive TB has to be done when we have a clinical syndrome suggestive of TB. Always attempt a microbiological diagnosis, whether it is a pulmonary or extrapulmonary TB case. Universal DST is under the program now, has to be done for all patients upfront by sending molecular and culture. Epidemiological risk factors, when we think about DRTB, go into the background and look for epidemiological risk factors as we discussed. Now there are only 2 treatment categories, drug sensitive and drug resistant, and wherever eligible for the context of pulmonary TB patients, rule out active TB and try to give TB preventive therapy to these patients. Thank you very much.
Thank you, Dr. Mane, for the excellent moderation.
I have one question. I have one things to say. As I saw the discussion, it is said in HIV positive patients, you have to have a history of contact. No, in HIV patient, if there is no need of having history of TB contact. Okay, in HIV patients, if HIV positive patients, if there is no active TB, you have to put on IPT. Provided that there is no contraindication of IPT. So in HIV positive, you don't need to have a history of TB contact, either in the children or in the adult too. Thank you.
So, no, it is not like that. So, if the patient is HIV positive,
yes.
Okay, the thing is, if he has active TB, even after completion of TB treatment,
even after completion, you have to give the IPT for 6 months.
Yeah, that is, but what we are talking about, the patient does not have TB, he is just HIV positive, and there is a contact in the house.
If there is no contact also, then also you have to give the, anyway.
No.
Yes,
no.
in HIV positive patients, if there is no...
Like that, no, it's not like that. It's not like that.
Sir, you should give the latest NACO guideline. If there is no history of tuberculosis, it's a disease.
We should talk to them. I don't know. I'm not aware of this.
201, you said 2021 guideline.
The latest
you see the 2021 guideline, it is there.
Ma'am, the Government of India guideline.
Yeah, I'm talking Government of India. If there's no...
clearly says that if
the
patient is less than 1 year,
let me clear first, all the patients who are HIV positive.
You need to have a contact if the patient is infant.
No, all the patient HIV
not
positive.
All the patient, ma'am. For IPT, if the patient...
I'm talking about HIV positive, not HIV negative patients. First rule out TB. If there's no TB, put on cotrimoxazole, iconazole CD4, then you treat the ERT, and then give the IPT.
Only HIV patients.
So what's your say?
Okay, so sir will throw light on it. No, as far as I know, it is not like that.
I think, we will all learn together. There seems to be some confusion here. My understanding is, if there is an HIV exposure to TB, then only you give IPT.
Yes.
If treated, which is considered as a prior exposure, we no more give IPT to every child who has, who is HIV positive, but we can always review it. If you have read somewhere, we can review it as a, no, madam, I am also referring to some guidelines.
Anyway, HIV patients in our day-to-day practice is very nil.
I am happy to learn.
Mane said about that. He is very clearly who are the children to be benefited with TPT. I think we will follow that.
Thank you, sir.